we see in these populations and how they do present in the neonatal period. So I tried to find a definition of a founder population, and the closest I could find was the definition for a founder effect. So the founder effect is the result of starting a new population with a low number of individuals called founders, so that the gene pool may not contain the same proportion of alleles at a given locus. And the example they give is the ABO blood group in Australian Aborigines, where they contain no B allele. So basically you have a small population of individuals, and then either because of various pressures or random chance, you get overrepresentation of that gene abnormality or gene marker. Now, in Manitoba, we're developing a multi-gene panel to look at the various founder mutations in Manitoba. So it will allow us to more easily check for these various conditions. We're not quite there yet. We still have some of the logistics to work out, but hopefully in the near future, we'll have available a founder mutation panel. I looked at that, and there's various mutations that we see in various populations, but the most common ones that we see in Manitoba are in our Mennonite population, our Hutterite population, our First Nations, as well as other populations, including the Ashkenazi or European Jewish populations, and various other groups have a few different mutations. There's at least over 100 different mutations that are there. Many relate to cystic fibrosis or breast cancer or hemoglobinopathies, but some of the diseases have multiple mutations, and the list goes on and on. This is a classic example of one of the conditions in our population. It's not relevant to neonatology, but it's a condition called X-linked congenital stationary night blindness. So this is an X-linked recessive disorder common in the Mennonite population. It causes difficulties with vision at night, decreased vision that can range in severity. Some people have relatively normal vision, 20/30. Some have quite poor vision, 20/200 or so. It's called stationary because it doesn't get worse over time, and it is associated with other features, including nystagmus. So knowing that there is this disease in this population allows us for very quick diagnosis and avoids the need for doing other genetic testing or other testing. Now, I just want to switch a bit to talk about some of the ethnic groups, and I'm not an expert on the various ethnic groups, but I did gather some information. A good resource that I used is the Queen's University Terminology Guide. And according to them, the word indigenous is an umbrella term for First Nations, including both status and non-status, Métis and Inuit. Most, but not all, reserve-based communities in Canada refer to themselves as First Nations. First Nations, Aboriginal, and more recently Indigenous are more current and are preferred by many in the community, though each has their particular nuances. The term First Nations can be applied to individuals, but technically refers only to those who have Indian status under Canadian law as part of a recognized community. Many Aboriginal people in Canada do not have this formal connection, and those who are Métis or Inuit should not be referred to as First Nations. Métis are a specific Indigenous and Aboriginal group in Canada with a very specific social history. Inuit are another Aboriginal group historically located in the Arctic and legally and culturally distinct from First Nations or legally defined Indians and Métis. The singular of Inuit is Inuk. In Manitoba, as of March 2021, there were 164,000 registered First Nation persons. A total of 93,800 persons, or 57% of the total population, live on reserves. There are 5 First Nation linguistic groups in Manitoba: Cree, Ojibwe, Dakota, Oji-Cree, and Dene. There are 63 First Nations in Manitoba, including 6 of the 20 largest bands in Canada. When I do a family history, I often ask about ethnic origin, but if it's Aboriginal, then I try and get more details. You know, are they Cree? Are they Ojibwe? From what area, or what reserve did their parents come from? As far as the Mennonite population, we did a review on the diseases found in that population years ago, and I'm just going to quote some of the statistics from there. The Amish, Hutterite, and Mennonites are all members of the European Anabaptist movement and trace their origins to the Protestant Reformation in the 16th century. The Mennonites are named after the Dutch priest Menno Simons and are divided into two ancestral groups, the Dutch German and the Swiss German. The Dutch German are the ones that we predominantly have here in Western Canada. They are in other areas as well. Swiss German are predominantly in the Kitchener-Waterloo area, although I understand we do now have a few populations here. Persecution of the early Anabaptists in Northern Europe forced the Mennonites to flee their ancestral lands. In Canada, Mennonites soon settled in all provinces of Western Canada and were eventually joined by a second wave of immigration from Russia in the 1920s, following the Russian Revolution. At the same time, groups from Manitoba and Saskatchewan, about 7,000, migrated to Belize, Mexico, and South America. Following the Second World War, a steady stream of Dutch-German Mennonites left the traditional farming life for areas, metropolitan areas such as Winnipeg. These Mennonites tend to be, some of the Mennonites tend to be strictest in following a lifestyle tied closely to the church with standard manners of dress and the use of Low German in daily life. The more conservative Mennonites are known as Old Colonies, Sommerfelder, or Bergenthaler, named after their ancestral Russian colonies. And this just shows the timeline of the Mennonite population. And we see what's called bottlenecks, where the population, for various reasons, has dropped over time. And that certainly can lead to an increase in random variation in the population. We also did a review of the disorders seen in the Hutterite population. The Hutterites are a genetically isolated population living in North American prairies since the late 1800s. The population now numbers over 40,000, majority who are the descendants of 89 founders. The population is named after Jacob Hutter, an Anabaptist leader during the Protestant Reformation. The history of the Hutterites is marked by recurrent religious persecution, resettlement, periods where they thrived and times where their numbers were reduced. The Hutterites were founded in 1528 in South Tyrol, which at that time was part of Austria. Between 1874 and 79, 443 of these Hutterites moved to the New World and established 3 colonies that known as Loits. And these include Schmidloit, Dariusloit, and Laerloit. On the Canadian prairies, World War I had created a labor shortage, so the Canadian government offered the Hutterites military exemption, religious freedom, and the right to have their own schools. Therefore, most of the Hutterites moved to Canada, forming 15 colonies in Alberta and Manitoba. Over the last century, the Hutterite population has expanded, and the current community exceeds 40,000 in 400 communal agrarian colonies in Canada, predominantly Alberta, Saskatchewan, and Manitoba, and some in the United States. So that was a background of the common populations. Now, I just want to talk a bit about when and why do we use a founder test. So we can offer if we have a founder panel, we can offer carrier testing to the parents. If we suspect that the fetus is affected with one of these disorders, we can do the test on a CVS or an amniocentesis. Or if we suspect a diagnosis, we can do testing in the newborn period on the newborn, later in childhood or adult when we're suspecting affected. The timing could be done anywhere in the life cycle, from preconception, during a pregnancy, in the newborn period, or later. And as I said, the diagnosis can either be part of a screening test where we don't suspect an abnormality other than they have the ethnicity, or we suspect an abnormality and we're wondering about a diagnosis. When we do make a diagnosis early in pregnancy or before pregnancy, we can talk about testing the partner. We can talk about use of donor sperm, pre-implantation genetic diagnosis. During pregnancy, we can talk about options such as termination or to help plan for delivery. In the newborn period, we can use this to monitor or advisory treatment or palliative care. Now, I just want to mention one of the toolkits that was developed by Tyler Pikus in genetics. If you just go into the address bar and type in wingene.ca, you'll get to the home page, and it has all sorts of information on that. But if you click on the Manitoba population, and this is just a screenshot of the top part of it, you'll see information and resources for various disorders in the various populations that we do see. Now, the classic example of a founder population is the Ashkenazi Jewish population. And these are the Jews from Eastern Europe. Most of the Jews in North America are of Ashkenazi descent. And testing for various mutations in these populations has been available for a long time. We offer screening tests for carriers. Two of the common diseases that we test for are called Tay-Sachs disease and Canavan's disease. They both start with a baby who's normal at birth and then gradual deterioration of brain tissue with eventual death early on. And so we offer carrier testing to for couples where they're of Ashkenazi descent. We offer prenatal diagnosis. I haven't seen any cases, but I have seen identified some carriers. Now, I looked through the founder list for the disorders that might be relevant to neonatologists, and these are somewhat incomplete list, and I'm going to try and talk about many, but not necessarily all of these disorders. Okay, I've divided the list into various categories. So first, I'm going to start with some of the conditions that are associated with dysmorphology or congenital anomalies. And this is where I'm going to ask the audience to see if they have any ideas or suggestions. Does somebody want to describe what they see in this case? Do you think these children or child are dysmorphic? I can't hear any answers.
Someone from the fellows room, speak up.
Noonan syndrome, like there's some webbed neck, hypertelorism.
Okay, so before you give me a possible diagnosis, can you describe the features that you're seeing?
Yeah, flat occipitus, low
Okay.
centimeters, hypertelorism, upward nostril, philtrum, I think it's short, and
Okay.
there's some webbed neck, and distally placed thumb, what we call it. It's a little bit.
So the other features that, so certainly there are down slanting palpebral fissures. There's hypertelorism here. Here's some other pictures with that. And again, I agree that there is brachycephaly that we see in here, the down slant. Do people know what this child has, or does anybody recognize this condition? And again, this is a founder effect. So this is actually a relatively common disorder in Manitoba in our Indigenous population. It's called Richter-Schinzel syndrome. We first described it in 5 families from northeastern Manitoba and northwestern Ontario. The families are of Saulteaux and Ojibwe descent with some Cree, and some of the other families are Saulteaux. We've identified the gene for this, and it's in the K1AA0, a mutation in this gene. So we now have testing for it. This is one of the conditions that we've seen either for dysmorphology. We'll see them sometimes because they have a cardiac anomaly. Often they present either prenatally or postnatally with an macrocephaly or with an abnormality in the posterior fossa. We've seen this as in babies where early on in the pregnancy, they were found to have an increased nuchal translucency. So this is one that we've recognized over and over again. I think we had a case here relatively recently. Have you guys seen Richter-Schinzel? How many have?
I did not see.
Would they come into that ICU?
They often go to an ICU initially, or then sometimes into the normal nursery, but certainly we see lots of babies because of the prenatal concerns of an increased nuclear thickness, the heart defect, or the brain abnormality detected early on. Okay,
I think we had one a couple years ago.
yeah, well, I think there was one more recent than that, but okay. All right, how about, do people know what's going on in this family?
Anophthalmia.
This is the more severely affected. You get the aberrant hairline here, but also the cryptophthalmus. This is a condition called MODA syndrome or Manitoba oculotrichoanal syndrome. We initially described it in 7 patients from a Cree Ojibwe from the Island Lake region. Later on, we found that there was a mutation in the FREM1 gene. And this condition is characterized by eye defects with upper eyelid colobomas, but also cryptophthalmus or anophthalmia or microphthalmia, triangular growth of hair extending from the scalp to the eyebrows, a bifid or broad nasal tip, GI abnormalities, including omphalocele and anal atresia. And here is one of our initial reports, and you can see the various findings. Some of them had cryptophthalmus or coloboma. Some had omphalocele, anal stenosis, other things. So again, this is a relatively common disorder that we see in several families in Manitoba. Okay, do people know what this baby or these babies have?
Is it trisomy 18?
Well, actually, these are babies that we, trisomy 18 is always on the differential, and we certainly had a number of cases where it was between the disorder that I'm going to talk about and trisomy 18. So it's always a thought because of the clenched fingers, etc., that it might be trisomy 18. But again, considering that this is a disorder that's exclusively seen in the Hutterite population, do people know what this is?
Is this Joubert?
No?
Oh,
Okay, so the other common disorder that we see in the Hutterite is Bowen-Conradi syndrome, and it's characterized by severe growth retardation. It is exclusively seen in the Hutterite population, and they have a high carrier frequency, resulting in, we estimate, about 1 in 35 or 350 live births. It's characterized by death in early childhood. We've identified the mutation in the EMG1 gene. It's autosomal recessive, but they have various features. So certainly the clenched fingers make one think of trisomy 18, but the facial features with the prominent nose and the prominent root of the nose, they're microcephalic, they have rocker bottom feet, etc. They go on to have very poor outcome with failure to thrive, etc. Okay, what is this?
I think we had a patient of Bowen-Conradi like 2 weeks ago.
Ah, okay, yeah, I think you did.
Mhm.
Yeah. And I don't think that the diagnosis, I think, was suspected prenatally, but I don't think we had testing prenatally, but they did relatively rapid testing after birth.
Yeah.
Okay, do people know what I'm showing here?
Molar tooth sign, Joubert.
Okay, exactly right. So this is the molar tooth sign, which is deepened interpeduncular fossa and abnormal superior cerebellar peduncles, making it look like a tooth inside there. This is an example of actually Joubert or Joubert-related disorders. Now, there's 2 neurological or recessive disorders, Joubert and Meckel syndrome. Joubert is characterized by a molar tooth sign on MRI, developmental delay, intellectual disability, hypotonia, ataxia, episodic breathing abnormalities, abnormal eye movements, and various other findings. Meckel syndrome is a lethal disorder characterized by an occipital encephalocele, cystic kidneys, and fibrotic changes in the liver, as well as polydactyly. In our group, we have described what's called Joubert-related disorder as an abnormality in the TMEM237 gene. It's seen in our Hutterite population. And we call it a Joubert-related disorder because it overlaps between those two disorders of Joubert and Meckel syndrome. So many of them had the molar tooth sign, but many of them had the encephalocele, and many did not. They had posterior fossa abnormalities, etc. So it overlaps between the two. The prognosis is quite poor. Now, in the Mennonite, or sorry, in the Hutterite population, there are other disorders that have cerebellar involvement. You can get Joubert syndrome type 21 due to a CSPP1 mutation, Joubert syndrome type 33 due to a PIBF1 mutation, and there's also a disorder called cerebellar ataxia with mental retardation, or also known as disequilibrium syndrome due to a deletion in the VLDLR gene. So whenever we see either prenatally or in the neonatal period abnormalities in the cerebellum in a Hutterite population, I tend to order all of these three. Okay. Okay, now I'm going to describe another case, and then again, let's see if we can figure out what this family had. So the two probands were dizygotic male-female twins born small for gestational age. They had microcephaly, deep-set eyes, bilateral microphthalmia, and cataracts, overhanging upper lips, and prominent nose. The twins manifested failure to thrive, recurrent pneumonias, hypotonia, or axial hypotonia, appendicular hypertonia, hyperreflexia, and progressive contractures. Despite high-calorie feeding, the twins showed minimal weight gain and no developmental progress. The girl died at 5 years, the boy died at 11 years. When we do the family history, this is a typical family history. Family 1 is a large family belonging to the Saulteaux tribe of ebb and flow band in Manitoba. It's an Indian reservation, the old terminology, with a population of about 500. The second family is an American Indian family from the Roseau River Band in Manitoba. And here is the baby's face and MRI. Do people want to comment on what they see on the MRI?
Okay. On the MRI, like the cerebellum is rudimentary and there's small ponton and the brain stem is very thin, like.
Okay, yeah. So the official report shows global cerebral atrophy with thin corpus callosum, global cerebral atrophy, and delayed myelination. This is one of the patients later on, and you can see the microphthalmia, the high bridge of the nose, large ears, upper lip over the lower lip, small chin, and camptodactyly. Do people know the diagnosis yet? And here's some of the other features. And certainly some of the features would make one suspicious of trisomy 18. This is again one of the founder conditions that we see. It was first described in 1974 in Manitoba and was initially called Pina-Shakir syndrome, but later on became known as Cough syndrome, which is cerebro-oculofacial skeletal syndrome. It's characterized by microcephaly, hypotonia, microphthalmia, cataracts, blepharophimosis, large ears, prominent root of the nose, micrognathia, wide space nipples, camptodactyly contractures, etc. We've done studies on the population. The primary are of Saulteaux tribe of the ebb and flow band in Manitoba. And then eventually we were able to identify the specific gene involved, and it's related to cocaine syndrome, which is the CSB gene. Okay, any questions on these disorders? Sorry? Is that a question or just a comment?
That was an overhead announcement. Sorry about that.
Oh, sorry. Okay. Okay, so now I'm going to talk about a different categories of disorders. And these are where treatment may be possible. One of the examples is alpha thalassemia, which is common in various groups. Do people know how alpha thalassemia is inherited? The fellows, one of the fellows tell me how alpha thalassemia is inherited?
Autosomal recessive.
Okay, can you be more specific? It is autosomal recessive, but it's somewhat unique in its inheritance pattern.
With variable penetrance, or
You need 4 genes, right?
Not exactly. Okay, so so alpha thalassemia, most individuals have 2 or 4 normal genes, 2 from mom, 2 from dad. People can be a silent carrier where they have 3 normal genes, gain 2 from mom, and in this case, 1 from mom or dad. A carrier will have 2 normal genes, and there are 2 ways you can be a carrier. You can have 1 normal gene on each chromosome, or both normal genes on one and none on the other. Hemoglobin H is a more severe disease, although many of these patients are asymptomatic, but some do require lifelong transfusions. And in this case, they have 1 normal gene. The most severe form is hydrops fetalis or hemoglobin Bart's, where they have no normal genes. Now, we offer screening to all people from Asian and other populations, and the screening is to check their MCV, ferritin, and a hemoglobin electrophoresis. Typically, the silent carriers would have normal routine studies, and unless you do molecular tests, you won't pick them up. Carriers for alpha thalassemia, whether they're in cis or in trans, tend to have a low MCV, a normal ferritin, assuming they're not iron deficient, and have a normal hemoglobin electrophoresis. So it's the low MCV that makes us suspicious. The testing recommendations are to test the mother in pregnancy or before pregnancy. If she's a carrier, then to test the partner. If they're both carriers, then to refer them to genetics. But if they're both like this, then that's the situation where they have a risk of having a child who's like this. Now, alpha thalassemia occurs predominantly in Asia or China and Southeast Asia. We have a fairly high frequency in North America, primarily due to immigration. And if you read about this disease in older articles, it's considered essentially a lethal disorder. Infants with hemoglobin Bart's, hydrops fetalis, almost always die in utero between 23 and 38 weeks or shortly after birth. A few cases were described in the neonatal period and given intensive life support therapy and treated with blood transfusions. But this is a case here from Manitoba, from the Cancer Care website. It talks about the twins, Zoe and Zane. The parents met in the Philippines. Unknowingly, both were carriers for alpha thalassemia. When the mom became pregnant with twin girls, they had a 25% chance of having a child with a severe form of the disease. Their first daughter was healthy, but the twins were affected with the severe form of alpha thalassemia, and they would go into heart failure at around 6 months in the pregnancy. They were seen by the fetal assessment unit, who performed in utero transfusions. The girls were born in 2013. They eventually arranged for bone marrow transplant. And as of now, when the article is written, after bone marrow transplant, they're both doing well. So this is the disorder that is traditionally considered a lethal disorder. But now if we can detect them in pregnancy, we do have the option of multiple transfusions throughout pregnancy with treatment after birth with bone marrow transplantation. How many of you guys have seen alpha thalassemia hydrops?
I think where I trained, it was common.
Okay,
In Saudi Arabia was, yeah, it was a pretty common.
okay, good, okay. So the next disorder that treatment is possible is a disorder that we've done a lot of work here in Manitoba, and it's called hypophosphatasia. Hypophosphatasia means low levels of alkaline phosphatase. Alkaline phosphatase is necessary to put the calcium and phosphate into the bones to make the bones of normal strength and density. There's various forms of the disease. It can present in the perinatal period or the infantile or in the newborn period, or later on in childhood or adulthood, and later on have either milder mutations or only carriers, and they present with either fractures or early loss of their teeth. But in Manitoba, we've seen a large population with the perinatal lethal form. This is an autosomal recessive disorder. Parents have low levels of alkaline phosphatase. The babies have almost no level or no alkaline phosphatase. And in the past, this was considered a lethal disorder. If the diagnosis was made in pregnancy or shortly after birth, the only option we really had was palliative care. Now we have an option of treatment with enzyme replacement therapy. And here's a case where it was done, and you can see on the x-rays, you can almost not even see any of the bones initially, but after treatment, the bones started to appear, and then they are on lifelong therapy. Now, when these babies are born, it's like other lethal skeletal dysplasias. The primary problem is a lack of or pulmonary hypoplasia due to the small ribs or lack of growth of the chest. So these babies do require intensive care until their lungs grow more normally. But it's clearly shown that treatment with the enzyme replacement can improve survival. These are two cases from Winnipeg. One was a baby born at 40 weeks gestation. He had respiratory distress from birth. He was treated with enzyme replacement. He was on a ventilator for 4 months. He was discharged home at 8 months of age, and at 10 years of age is doing well. Another case was born at 36 weeks after antenatal diagnosis, treated with enzyme replacement from birth, on a ventilator for 300 days, but died at 18 months of age. He had a sibling born who was also affected, and this sibling was treated with comfort care, as a family did not want or chose that given their experience with their previous ones. So certainly this is a disorder that we've had lots of experience with, but it does bring various challenges. Prenatally, making the diagnosis, is the disorder osteogenesis imperfecta or hypophosphatasia? There is described a benign form of perinatal hypophosphatasia. We've not seen it in Manitoba, but it does exist. Should all babies with perinatal hypophosphatasia be offered enzyme replacement? We know that it's certainly effective, but there certainly can be complications. If we're offering, when do we begin it? Do we talk about delivering early? And this is one of the conditions that certainly involves a multidisciplinary team. I've been involved in several cases prenatally, and again, we go through the various discussions. Do we continue with the pregnancy or consider termination? Do we just go plan for the palliative care route? Do we plan for treatment? Do we plan to assess and then decide on treatment, etc.? So it certainly becomes a difficult management case. Again, I can't remember when was you guys must have seen some cases in the last couple of years.
I saw one at the palliative care, comfort care, evident.
Okay, so with the remaining time, I'm just going to talk about some other diseases that you might see. One of the conditions, certainly that presents in the neonatal period is polycystic kidney disease, or specifically the autosomal recessive polycystic kidney disease, also known as infantile polycystic kidney disease. if you look up the reviews on these articles, the majority present in the neonatal period with enlarged echogenic kidneys. More than 50% progress to end-stage renal disease within the first decade of life and eventually may require transplantation. Severely affected individuals with oligohydramnios may have pulmonary hypoplasia and high mortality due to the lung insufficiency or multiple intrauterine compression anomalies, which is what we call the pattern sequence. About 30% die in the neonatal period or less than 1 year from respiratory insufficiency or superimposed pulmonary infections. So this disorder is seen in all ethnic groups, but we do have 2 specific mutations that are seen in our First Nation population and 1 specific mutation seen in our Inuit population. Both of these mutations are associated with very severe disease and very poor prognosis. From a prenatal point of view, certainly whenever I see someone from this ethnic group with either echogenic kidneys or oligohydramnios or other things, it's very easy for me to test the parents to see if they're carriers for this. Often because of the oligohydramnios, I can't test the fetus, but we've made the diagnosis prenatally in several cases, and that has allowed us for more easy management afterwards. I should mention that we've seen 1 Syrian family, which what's being described as a Saudi mutation. And this is actually, even though it's autosomal recessive or infantile polycystic kidney disease, it's associated, it's a milder mutation, and the renal function tends to be normal prior to birth. So these babies are born with normal lung function, but they do have echogenic kidneys and eventually go on to have early childhood renal failure. It just, they don't get the associated lung disorder. Okay, let's talk about this case. This infant had persistent non-bile staining vomiting from birth. Skin lesions, i.e. bullae, were first noted on day 2 on the left, middle, and index fingers. Similar lesions appeared gradually on all skin surfaces. He had a laparotomy and where it showed that there was no pyloric lumen, a gastroduodenoscopy performed. Postoperatively, she tolerated formula feeds, but by day 10 or day 19, developed bloody diarrhea and vomiting, anemia, failure to thrive, etc., and died at 68 days of age. And so this is an example of epidermolysis bullosa, not necessarily this disorder, but this is what the skin lesions would look like. This disorder was first described in 1978 by Dr. Groot, who was a pediatrician in Winnipeg with a large practice in northwestern Ontario. Dr. Postuma was a pediatric surgeon, and Alistair Hunter was a geneticist here. So it's known as familial pyloric atresia with epidermolysis bullosa. The gene mutation has been defined, and the family in this report is family F with an isolated Aboriginal community. The newborns were diagnosed as pyloric atresia with surgery, and in most cases, blistering after birth. This particular one is a lethal abnormality, although some of the other variants in the mutation or in the gene are not considered lethal. Just briefly want to talk about this family that I've seen. All these males were affected with cleft palate, and you can see that it goes through the female line here, although this person probably was affected as well. We don't know it. They also had associated with tongue tie, and the tongue tie can be seen in some of the carriers as well. So this is one of the inherited causes of cleft palate, and we've seen that in our Mennonite population in Manitoba, and the gene for it has been identified. Okay, what do people think of this case? This is a child presented at 7 weeks with a 4-day history of respiratory distress requiring assisted ventilation. By 8 weeks, her limbs and trunk muscles felt stiff. Fluoroscopy showed absence of diaphragmatic movements. She had an elevated CK of 1765. over the next 20 weeks, all of her muscles that initially felt rubbery, in consistency became increasingly rigid. Voluntary movements and joint mobility became progressively decreased, as did her ability to suck and swallow. Chest expansion became progressively limited because of worsening board-like stiffness and rigidity, and she died at 7 months of age. How many people have seen babies with this condition? And do people know what this is?
We've had one baby in the NICU, but I can't remember what it's called.
Okay, so it used to be called fatal infantile hypertonic muscular dystrophy, although nowadays we just refer to it as hypertonic muscular dystrophy. It's again an autosomal recessive disorder. It's seen in our Aboriginal population. We've seen it from Barons River, Pekanjicum, Poplar Hill. Typically, they don't present right at birth, although this one apparently did, but usually in a few weeks after birth. And the presenting symptoms can be respiratory distress, hypertonia later on. But one of the main characteristics is a very high CK level. So whenever I see a baby where I'm suspicious of this, one of the first things I'll check is the CK level. The gene for this disorder has been identified, and we can rapidly do this test. Okay. There's another condition that we've seen in our Hutterite and Mennonite population called restrictive dermopathy. Here's an example of a baby who was delivered at 33 weeks, multiple dysmorphic features consistent with the diagnosis of restrictive dermopathy were noted, including thin, tense, and translucent skin, a narrow nose, short palpebral fissures, closely spaced eyes, narrow mouth, and multiple joint contractures or arthrogryposis. Given the lethal prognosis, palliative care was initiated and the child died at 1 age of age. And this is what a child would look like. So it's primarily because of the tightening of the skin that you get the multiple joint contractures. We've identified some cases prenatally as having arthrogryposis, and we're subsequently able to make the diagnosis. Okay. I'm not sure whether you guys would be involved in the care of these babies, but this is a large Hutterite family where multiple we see multiple loops of consanguinity, which is not surprising in the population, but we see multiple affected individuals, both mostly female in this case, but both males and females affected, and certainly consistent with an autosomal recessive disorder. And this is one of the inherited causes of congenital hypothyroidism. So this would be picked up on newborn screening. Now, most cases of hypothyroidism are non-inherited due to lack of development of the thyroid tissue, but this is one of the inherited causes due to a mutation in the sodium iodide symporter gene, and we've seen many cases over the years with that. I'm not sure they would actually go to NICU, but certainly the endocrinologist would be quite involved in their management. Okay, what do people think of this MRI? Even though I guess I showed you what it showed. But if you saw this MRI, what would you think would be the prognosis?
Not bad.
Why, when you say not bad, what do you mean?
I mean, there is well-formed cortical matrix. I think it's just like the ventricular dilatation, and I mean, that's significant. Apart from that,
okay. If I told you this was a Mennonite baby, you know what the diagnosis might be?
yeah.
Okay, so obviously the babies do have severe ventricular. There are other brain abnormalities, polymicrogyria, etc. Looking at that, I might have thought that the prognosis was poor, but in fact, these children do relatively well. They do have an associated profound hearing loss. And their development tends to be either normal or mildly delayed. This is a disorder that we've come to recognize as Chudley-McCullough syndrome. Dr. Chudley, I'm not sure how many of you remember him, but he was the head of medical genetics until he retired about 7 years ago. And he described several Mennonite families with this. So again, having a specific founder mutation allows us to do relatively early tests, allows us to give more information about prognosis, and to make sure that we arrange for hearing tests. That's one of the reasons why quickly on, if I see a Mennonite baby with hydrocephalus, I'll always ask for a hearing test to be done. And the mutation has been identified in this gene. Okay, now this is a disorder that I don't see since I don't see metabolic patients, but we do have a form of pyruvate carboxylase deficiency seen in various Aboriginal populations, including Micmac, Cree, and Ojibwe. The common group is from a founder group in Southern Ontario. Patients who have this present either at birth, for many of them, or later on. Presenting signs are metabolic acidosis, seizures, respiratory distress, and it's one of the things in the differential diagnosis of lactic acidosis that's quite severe, and then the associated problems with developmental, etc. Many of these babies did not survive, but many did survive for a longer term and had significant developmental delay. I won't necessarily go into the metabolic pathways, but it's because of the block here, you end up developing a lactic acidosis. So pyruvate carboxylase catalyzes pyruvate to oxaloacetyl acetate. It's pivotal in 3 pathways: the TCA cycle, gluconeogenesis, and lipogenesis. And we've seen, the infantile, it causes type A causes infantile lactic acidosis with developmental delay. Type B causes neonatal severe lactic acidosis, and there's a milder form. And it depends on how much enzyme activity. But the form that we see here is primarily the type B, which is seizures, hypotonia, rigidity, lactic acidosis, high ammonia, and then early death. So that was a fairly quick overview, and I'm going to stop sharing my slide for now, of multiple disorders that we see in our populations in Manitoba. The list of founder populations include many disorders that are unrelated to neonatology, but certainly many of these disorders are related, and they will present either with metabolic abnormalities, dysmorphic features, or other problems. I think the take-home message is that we should think of these. We should always ask about ethnic background. Certainly, I've learned over the years to recognize the various names associated with the Hutterite population or the Mennonite population. And knowing these disorders exist allows us for more rapid diagnosis and more information on prognosis. Questions?
Thanks, Bernie. That's always fascinating. Sorry, I'm not feeling super well, so I don't sound very good. It's my understanding that there's quite a lot of cleft lip and palate in the Indigenous populations. Is that multifactorial?
I think so. It is a higher frequency. No specific gene has been identified, so it may be related to environmental factors or just common, not single genes, but multiple genes that are in that population.
And how many of these, and do you offer antenatal screening for all of the disorders that, like, especially the fatal or the like almost universally fatal ones?
We're just in the process of doing that. We need to get the founder panel up and running, but certainly our hope is that in the near future, when we see Hutterite families, we'll offer them testing for the broad condition panel. The other ones, there's no organized screening program. But certainly when we have a suspicion of the disorder, whether it's based on polycystic kidney disease or increased nuchal translucency, these are one of the conditions, these are some of the tests we can do. I know the last case of Richard Sinzel, it was basically we had the brain abnormality and an increased nuchal, and we ended up doing that test.
I don't know how you remember all these syndromes. We need, Brar is our house officer that always remembers them. We have to ask him when you're not available. I can't keep them all straight.
Well, but again, you don't necessarily have to. Like I say, if you go, if you just put on the address bar wingene.ca, and that takes you to various resources, but go to the Manitoba population page, and you'll see what's this, these are the sort of described in Hutterites, Aboriginals, Palestinians, or whatever that we've identified here. And you can quickly go through that. And often what I'll do is if I see a Hutterite baby, I'll go to my review article and, sort of search for cerebellum or kidney or whatever. Any other questions?
Hi, Bernie. My
Hi.
question about hypophosphatasia. How is it presented antenatally if you are offering prenatal screening? What's the usual presentation?
So often we will see some of the families because of a family history. That's easy. There's now when a warning that goes out, if somebody has a low level of alkaline phosphatase under 30 or so on a routine chemistry test, the lab will say low alkaline phosphatase has been associated with hypophosphatasia, consider referral to genetics. So sometimes we know about the family before there's a specific problem. But in many of the cases, it presents like a skeletal dysplasia, showing either fractures or bone density, short femurs, etc. So it's primarily ultrasound findings suggesting a skeletal dysplasia. For us, the differential is there's a long list of skeletal dysplasias, but once you get into the decreased bone density category, is it osteogenesis imperfecta or is it hypophosphatasia? In that case, if we know that they're Mennonite, then it's easy for us to do the mutations. Even if they're not Mennonite, I often will check the alkaline phosphatase in the parents to see if that's suspicious. We've had one case where we didn't make the diagnosis initially, but then ordered a skeletal dysplasia gene panel and made the diagnosis that way.
Thank you.
Okay. Any other questions? If not, we'll leave it at that.
That was
Thank you.
fascinating as always.
Thank you, guys.
Thank you,
Okay,
Doc.
Bye-bye.
thanks, Bernie.